welcome. Thank you for joining us to the Lehman Center for American History's 2020-21 series in race, inequality, and health. I'm pleased to welcome everyone. My name is Samuel Roberts. I'm an associate professor here in the Department of History, also in the Department of Socio-Medical Sciences at the Mailman School of Public Health, and also in our newly created Department of African American and African Diaspora Studies. Welcome to all of you. It's my pleasure to welcome you and to host this evening's speaker, Dr. Richard Mizelle. But first, a little bit about the Lehman Center, which is a collaboration between the Rare Books and Manuscript Library and the Department of History here at Columbia University. The Lehman Center is dedicated to supporting and enhancing the study and teaching of history here at Columbia. In the fall, as we were preparing to relaunch the center with a new slate of events and programming, we decided it was more critical than ever to engage historical scholarship that offers us tools and perspectives to make sense of the contemporary crises we're facing in the United States. This past year, we've seen the explosion of a global pandemic, which to date has resulted in nearly 450,000 deaths, just in the United States alone. That has been exacerbated along tragically familiar lines of race, class, and other vectors of inequality, and really structures of inequality, I might add. On top of that, we've seen what has been described as the largest wave of protests in the history of this country, particularly last year, but continuing till today, a courageous wave of uprisings in response to entrenched white supremacy and police violence. And all of this has happened amidst a toxic and divisive political culture in which, until recently anyway, no norms of decency or basic civility appear to have been safe. In this context, we have asked ourselves, what does history have to offer? And in response, and to rise to this challenge, we framed this year's events at the Lehman Center around themes designed to tackle these questions head on. My colleagues here have shaped two series of new talks, or new book talks rather, on the themes Policing America, which digs into histories of law enforcement, racial violence in the prison industrial complex and the carceral state, and then also a second series called American Politics, American Identities. This one explores the significance of race within voting patterns and political movements. For videos of these events, past events anyway, please see our brand new website. It's a beautiful piece of work, lehmancenter.history.columbia.edu. That is Lehman Center, LEHMANCENTR.history.columbia.edu. Today's talk is part of a lecture series on the theme, as I said earlier, of race inequality and health. Last semester, Dr. Marcia Chatelain joined us to discuss her new book, Franchise, which looked at racial justice and fast food in Black America. Looking ahead, we'll host Maria John on March 11th, who is an alum of this department, and she will speak about urban indigenous healthcare activism. And then 1 week later, on March 18th, same time, 4 p.m., we will have Dan Royals, who will speak about Black gay organizing during the AIDS epidemic of the 1980s and 90s. So please stay tuned in the spring for many more critical conversations about these urgent issues. So today, we are delighted to welcome Dr. Richard Mizelle for our third lecture in the 2020-21 Race, Inequality, and Health series. Dr. Mizelle is Associate Professor of History at the University of Houston. He is the author of the fantastic Backwater Blues, The Mississippi Flood of 1927, and the African American Imagination. This is a wonderful work. I'm going off script here, but I can't go without saying this. It's a wonderful fusion of environmental history, history of science, technology, and society, cultural studies, African American studies. It's all fused into this wonderfully researched and written book. The title again is Backwater Blues, The Mississippi Flood of 1927 and the African American Imagination. Dr. Mizelle is co-editor of Resilience and Opportunity, Lessons from the U.S. Gulf Coast After Katrina and Rita. His research focuses on healthcare politics, medical citizenship, environmentalism and health, medical technology, and the transformation of disease identity. He's published in a wide range of academic and public venues, including the Journal of African American History, the Journal ISIS, Open Rivers Journal, and the American Historian magazine. His research has also been quoted in ProPublica, the New York Times, the Washington Post, and the New Yorker magazine. He is currently writing a history of race and diabetes in the 20th century and co-editing the Oxford Handbook of American Medical History. Rick, if we were all in a room together, this is where you would hear the thundering applause of welcome, but you will just have to imagine that our participants list is growing even as we speak, and they all, as I do, welcome you to Columbia University. Thank you so much for joining us. And with that, I will turn this over to you. Thank you so much.
Thank you. I will share my screen here. Actually, well, I would like to thank the Lehman Center for American History for this invitation, and especially Professor Sam Roberts for this wonderful invitation. I'm very glad to be here. I want to thank everyone also out there in Zoom land for giving me a bit of your time on this snowy New York City afternoon to listen to a bit of my ongoing research. As Professor Roberts stated, I am writing a history of race and diabetes in the 20th century. And this talk that I'm giving you today is a small slice of that larger research project. As I often say when talking about diabetes, this particular disease really narrates the 20th century, the entirety of the 20th century. There is no point of the 20th century and really into the 21st century that diabetes does not encounter or touch. From the Progressive Era to the Great Migration, the Depression, World War I, World War II, the Civil Rights Era, the Black Power Movement, the post-Civil Rights Era. Diabetes plays a role in every aspect of American society. And so my project really spans the turn of the 20th century to now the SARS-CoV-2 pandemic. 2 years ago, I would have said that this project ended with Hurricane Katrina. But as you might imagine, with the recent events in the world, I now will sort of extend this project to a discussion of the current pandemic. So I'm at a very interesting and good point in this research project. I've begun writing. I just recently completed the introduction, which I always start with the introduction, and I understand that the introduction will change once I write the entire book project, but I always have to start with the introduction. And I say that I'm at a good place because I'm coming to a realization of what this project is about. And perhaps what's more liberating, I'm also coming to a realization of what this project is not about. And you know, as someone who often casts a wide net, I have a tendency to want to write and think and talk about everything. And so as I narrow this project down to the point where I understand what it is that I want to argue and say and contribute, some of these more salient points are coming to light. And I've come to understand that part of what I've really been interested in with this project are the complications of diabetes. I'm very much interested in sort of the complications of diabetes, of heart disease, of kidney failure, of amputations, of blindness, diabetic headache, which people often do not talk about. And the complications of diabetes tell us a lot about the long and tortured history of this particular disease. And so some of my spinoff projects also deal with these complications, writing about amputations, but also writing about early dialysis in Seattle Artificial Kidney Center in the 1960s, and how that influenced how diabetics were understood in the 20th century. So this project includes these sort of larger narratives of diabetes. So I want to do two things with this talk this afternoon. The first is talk a bit about one of the deadliest complications of diabetes, amputations, and how we might think about this ever looming yet largely invisible public health threat. Secondly, I would like to talk briefly about how we might think about amputations and, to a larger degree, diabetes during the current SARS-CoV-2 pandemic. So type 1 or diabetes, just to give you a little bit of a brief background, diabetes is by and large a beta cell pancreatic disorder. Today, what we consider to be type 1 diabetes is the result of the body failing to produce insulin in sufficient amount, leading to what we call insulin dependence. Now, traditionally, this has been called juvenile diabetes because most of the those individuals diagnosed were diagnosed in childhood. Type 2 diabetes, which traditionally we call adult onset, because most of the symptoms or complications occur into adulthood around age 30 or 40, results from, at first, insulin resistance. The body might produce insulin in sufficient quantity, but the cells and organs become hard of hearing, so to speak. In compensation, the body might produce more and more insulin, which will rectify the situation for a time. But if the body, if diabetes is not brought under control, then insulin will not work in the body, and the person will become insulin dependent as well. And so the statistics of diabetes are staggering, and I must admit, I should update this slide. These statistics might even be a bit low from a couple of years ago. But the World Health Organization has counted roughly 16 million people in the United States who are suffering from diabetes. By 2025, the CDC has argued that there will be roughly 270 million people worldwide who will suffer from diabetes. In the United States, 500,000 are on dialysis, and another 1 to 2 million worldwide are on dialysis for diabetes, kidney failure, or end-stage renal disease. Insulin, roughly 8.3 million type 1 and type 2 diabetics in the United States require some form of insulin for survival, and another 30 to 40 million type 1 and type 2 individuals require insulin across the globe. So you can see already these complications of dialysis, of kidney failure, and insulin, and the lack of insulin, and what it might mean for these complications, and this long tortured history of diabetes. So that's part of what I would like to talk with you about today. And I want to start with this conversation around Eric Dolphy. And I want to begin with Eric Dolphy because in some ways he encapsulates in many ways what this project is about. Eric Dolphy was born in 1928 in Los Angeles. He was a jazz musician during the bebop era. He played 3 instruments, the saxophone, the clarinet, and the flute. Some have argued that Dolphy was one of the first musicians to bring flute into the jazz genre. In a way that was powerful and at the front and not just in the background. Critics have argued that he was under-recognized as a jazz musician. His best album for many critics is the album Out to Lunch. Others have said that much of his best work was in front of him before his untimely death. Eric Dolphy was touring in Berlin in 1964 when he slipped into a diabetic coma. Now, it's unclear whether he slipped into this coma at the hotel or backstage. Those details have have largely been unclear. But he slipped into a diabetic coma and he was rushed to a Berlin hospital where he never did come out of the diabetic coma, and he died a couple of days later. Now, his family and friends did not know that he was a diabetic. To their knowledge, he had never expressed to them that he was a diabetic. He did not give any inclination that he was suffering from diabetes before this incident. But what those around him would say was that in the days leading up to his death, he was urinating copiously and he had an insatiable appetite for sugars and sweets, could not stop drinking Coca-Colas and could not stop eating honey buns. And what his family and friends will also say is that Eric Dolphy was the victim of medical neglect in this Berlin hospital. That upon seeing this person in their hospital bed, physicians assumed that he was African-American, Black, and jazz musician, and therefore he was a heroin addict. They never did any of the tests to inquire or to see whether he might be suffering from anything else, even though many of his symptoms were that of a diabetic. So there are a lot of questions that I've had for this particular incident. Did any of the physicians test his blood sugar? Did they talk to his friends who brought him to the hospital about his recent behavior? All of these things are unclear. Instead, they put him on anti-narcotic or anti-drug medication because of the assumption that he was a heroin addict. And so if they had talked to Eric Dolphy's family and friends, they would have known that he was notoriously straight-laced, right? Didn't use drugs, rarely consumed alcohol. But the larger issue is the assumption and the stigma of his status as a drug-seeking, drug addict African-American from the United States, and therefore could not suffer from any other form of disease or illness. Now, Dolphy's death is interesting for other reasons as well. First, as I mentioned, type 1 and type 2 diabetes is how we think about this particular disease today. But our understanding of type 1 and type 2 diabetes really did not come into being until roughly the 1950s, particularly with the emergence of autoimmune diseases. So type 1 diabetes is, by and large, an autoimmune disease. And so our understanding of sort of type 1 and type 2 is a relatively recent origin. And so Eric Dolphy, who was of a relative advanced age at 36 when he died, the assumption might have been that he was a type 2 diabetic, but many people actually believe that he was a long undiagnosed type 1 diabetic. And so what does this mean in terms of the legacy or the long-standing history of misdiagnoses among African Americans? And this also taps into the slippage of type 1 and type 2 diabetes. We often think that there's a hard line of juvenile and adult onset diabetes. But of course, individuals who are young or childhood can be diagnosed with type 2 diabetes, and individuals of an advanced age, adulthood, can also be diagnosed with type 1 diabetes. And secondly, Dolphy's death highlights a long history of medical neglect. Black diabetics were misdiagnosed and ignored in the early 20th century, mid 20th century, all the way to the current day. And in fact, many type 1 African Americans have to fight and sort of lobby for their treatment, but also for their visibility within diabetes campaigns and for the awareness of their status among physicians who assume that because they are African American, they must necessarily be type 2. For a long part of the latter part of the 20th century, the assumption has been that whites suffer from type 1 diabetes and only African Americans suffer from type 2 diabetes. And so Eric Dolphy's story in many ways sort of highlights this medical neglect and mistrust and mistreatment among African American diabetics throughout the 20th and into the 21st century. So Dolphy's neglect tells us something about the current diabetes amputation epidemic as well. Diabetic amputations represent an epidemic within an epidemic. Uncontrolled diabetes causes severe nerve damage and hardening of blood vessels that restrict the flow of blood to the lower extremities. Restriction of blood and nerve damage leads to gangrene, infections, foot ulcers, and peripheral arterial disease. The loss of sensation in toes and feet are a troubling sign of poor insulin management and nerve damage, making diabetics vulnerable to sores and wounds that go undetected or do not heal properly. A scratch, skin break, or stumping of the toe can become deadly for diabetics. Surprisingly, diabetics who suffer high amputations or amputations above the knee have a shorter life expectancy than most forms of diagnosed cancer. Now, I'll just say that it's not easy to surprise me, right? So I see a lot of statistics. I read a lot of statistics, but when I first came across that statistic several years ago, I was a little shocked, though I did understand, and it wasn't intuitive. It was kind of understanding how, diabetes ravages the body, and the hardening of the blood vessels and restriction of blood flow that occurs in the lower extremities also occurs in other parts of the body, particularly in the vessels to and from the heart. So that restriction of the blood flow causes or can cause massive heart attack, stroke, hypertension, and also other cascading issues within the body. And gangrene infections cause death as well. But I understood that amputations are in many ways the outward symbol of the devastating image that diabetes has caused inside the body. But I also think that there's a psychological component to this as well. There is something psychologically damaging and frightening about losing a limb that we also must discuss. And so this sort of understanding of how the death toll of individuals who are suffering from diabetes, sometimes in the range of 5 to 6 years after a high amputation, is something that we really need to address. And so as early as the Civil War, physicians understood amputations might reduce a soldier's lifespan. Where amputations occurred also mattered. Civil War scholars have made the case that over half of soldiers in the Union and Confederacy suffering from amputations of the femur or at the hip ultimately died. The poet Walt Whitman recalled the carnal scene of amputated legs, arms, and feet piled up under a tree after the Battle of Fredericksburg in 1862. Part of the roughly 30,000 amputations performed by Union surgeons alone. So, fears of amputation-related deaths are nothing new. Nearly 50% of diabetic amputations in the 1930s resulted in death. And so, it's also important to understand that this project deals with, in many ways, other forms of intersectionality, music, novels, poems. Amputations come up in a lot of this kind of literature. And I use all of this as a way of understanding what amputation, what the cutting of the body, what the complications mean for those individuals suffering from diabetes. In this particular slide, Cannonball Adderley was a long diagnosed type 1 diabetic. Many people in his inner circle understood that, and they sort of used his story as a way of sort of diagnosing or highlighting the fears and dangers of diabetes and fear of amputations in the broader public. B.B. King was also a well-known diabetic in the latter part of the 20th century. And Malik Taylor of the popular group, A Tribe Called Quest, who in a 1993 song, Oh My God, uttered the words, when's the last time you heard a funky diabetic? Malik Taylor had been diagnosed with diabetes. In his mind, this lyric was something that sounded good, but it was also an accurate description of his body. He really did not realize the interactions that he would have with people when uttering this line, of people coming to him saying, I have diabetes too. I'm fearful of having my leg amputated. I'm fearful of going on dialysis. He would later say in a documentary, he was taken aback, quite frankly, at how many people had never heard of diabetes or had heard of diabetes and really didn't know what it was, and began to look at what this disease was or meant after hearing this particular song. And so from Dolphy to Malik Taylor, these questions of sort of the complications of diabetes are front and center in this project. Malik Taylor died in 2016 from complications of diabetes, particularly kidney complications of diabetes. One of the individuals who understood in the early 20th century the complications, the deadly complications of diabetes, was Elliot Joslin. Elliot Joslin was one of the first diabetologists. He became interested in diabetes in the late 19th century while in medical school. His aunt would come down with diabetes, and he realized that he knew very little about this mysterious disease, and set himself upon a path to understand diabetes, and would become one of the leading figures of diabetes throughout the 20th century, setting up a practice in the Back Bay section of Boston. He also wrote many of the first diabetes handbooks and textbooks as well. And Joslin wrote in the 1950s about a patient's death after a mid-thigh amputation, and talked specifically about the risk of amputations among all classes, but especially the poor. Foot ulcers and gangrene have plagued diabetics for centuries. Yet diabetes-related surgery and amputations were not common until the early 20th century. Prior to surgical advancements and rise of antisepsis in the mid to late 19th century, the fear was that amputating limbs would lead to deadly infection and gangrene. As I was telling Isabel before we all got on, I had planned on finishing much of this research last spring when I had an off semester in the summer. And one of the archives that I missed out on because of the pandemic was the Joslin archives. Many of his records show up in other places, but the large Joslin archive is in Boston. And that is sort of what I need in many ways to bring together the last bit of this particular project. And I suspect that there's a lot more about complications and amputations within the Joslin papers. And the fact that so many people suffer amputations in the 21st century beyond accidents and warfare is surprising to many Americans. In a moment where scientists are working on gene expression to turn off cancer cells, mobile monitors can track everything from low glucose to high blood pressure, and vaccines continue to emerge to deal with some of the world's deadliest diseases, amputations seem like an outlier to our medical and technological progress. Yet, the A word brings debilitating fear, and for good reason. Roughly 140,000 diabetic-related amputations occur every year. African Americans are 4 times more likely to suffer amputations. Low rates of angiogram screening for nerve damage and PAD leads to unnecessary amputations. Zip codes tell the story as residents in low-income and neglected neighborhoods suffer amputations at rates double that of higher income communities. Diabetics living in poor and segregated neighborhoods experience a constellation of social factors that lead to risk of amputations, including being uninsured, high insulin costs, and lack of access to revascularization surgeons and large research hospitals. Revascularization is the process of going in and clearing up reduced blood flow in a way that could prevent amputations. So revascularization surgeons and procedures, if done in a timely fashion, could actually reduce the amount of amputations considerably. And part of this revolves around medical deserts. And what we know is that regular access to foot care specialists, nutritionists, ophthalmologists, and other diabetes specialists reduces the risk of amputations and other complications. Regional hospitals and clinics serving low-income and Black communities are more likely to perform amputations over their early screening procedures that might save limbs. This particular slide talks about the roughly 600 rural hospitals that are in danger of closing, notably in Georgia, Alabama, Mississippi, and Oklahoma. But medical deserts aren't just about rural America, it's about access in all aspects of American society. Where I live here in Houston, is home to the Texas Medical Center, one of, if not the largest medical center in the world, some have argued. But the people living in the shadow of the Texas Medical Center actually do not have access to much of its services. They have to get on a drive or get on a bus across town to another part of Houston or a suburb to access medical care, even though people are flying into the Texas Medical Center from all over the globe for cutting-edge cancer treatment. Food deserts are an important part of controlling diabetes as well, as access to healthy foods can be difficult and travel to healthy markets burdensome. Neglected neighborhoods still suffer from a lack of usable green space and parks for exercise, and following an amputation, exercise can become even more difficult. Now, I use this image of Walter Mosley. He's one of my favorite novelists. This book, Always Outnumbered, Always Outgunned, is one of the first texts, I think, to really sort of engage novels, to really engage this idea of a food desert. The main character is a man by the name of Socrates Fortlow, who must take 2 buses to get to the nearest supermarket. And he takes these 2 buses to his nearest supermarket every other week for food, but one day decides to apply for a job. And the supervisor says, well, where do you work? And he says, Watts. And how would you get to work if we did offer you this job? And Fortlow says, well, I would get to work the same way I got here today to apply for this job, take 2 buses. And so Mosley, I think, in imaginative ways, sort of shows the difficulty of people living in spaces that do not have resources in their community. But it also shows the ways in which novels, imaginative literature, and other creative forms can really have an important emphasis or important role in scholarship and research, particularly when firsthand patient resources are not always available. And so immobility is exacerbated by the physical and social pain of limited employment opportunities, loss of self-sufficiency, embarrassment and spectacle of public debility, and fear of losing additional limbs. So part of my larger point here is that to understand the amputation epidemic, you can't just go into one point, right? You can't say that people are being sort of mistreated in healthcare. That's an important part, but you also have to look at where they live, whether they have access to physicians, whether they have access to dentists, whether they have access to supermarkets. And once they have access to a physician, how are they treated? Are they given the opportunity of revascularization, or is the norm to go straight to amputations? And so it's a cascading effect that occurs when poor people interact with their environment, but also the medical environment that leads to this amputation epidemic. And so part of how we must understand this is that policies must be broad enough to deal with housing, broad enough to deal with sort of jobs, and broad enough to deal with physician bias that leads to this amputation epidemic. And sort of picking out one, it will not be good enough. That we have to sort of look at the collective experiences of people who are interacting with these environments and within these spaces as well. Amputations are also financially expensive. Prosthetic limbs can cost up to $50,000, require replacement every 3 to 5 years to account for changes in the body, and demand months of physical therapy that can be economically prohibitive. Medicare and many Medicaid plans cover prosthetics, though the bureaucratic enrollment and state eligibility requirements for the latter can make access difficult. Prosthetics also speak to questions of race and technology. In her 2014 dissertation, Prosthetic Promises: How Bodies, Technologies, and Cells Contribute to Amputee Identity, Cynthia Sharer framed the ways in which prosthetic legs formulate and construct human identity. Far from apolitical technologies, prosthetics tell us something about whiteness as the constructed technological norm and the politics of user identity. Building on the work of sociologist Irving Goffman, Sharer writes of how legs speak of the self. For African Americans, the stigma of amputations in public spaces can be exacerbated by the inability to find prosthetic limbs to match their skin color, forcing the use of pants, and for women to sometimes wear dark stockings, even in the summertime. Foot shells are the covers made to look like human feet for prosthetic limbs, and they can also be difficult to find in colors other than white for those without resources. There is pain and frustration here for people who are non-white, but out of necessity are forced to walk around with a white prosthetic limb on their non-white bodies. In 1997, social theorist Langdon Winter asked the question, do artifacts have politics, influencing a generation of scholarship on the meaning of technology and society. In 1997, he writes, at issue is the claim that the machines, structures, and systems of modern material culture can be accurately judged, not only for their contributions to efficiency and productivity, but also for the ways in which they embody specific forms of power and authority. Technology is inherently political, Winter writes, in that it reflects human bias in both design and application. More recently, sociologist Ruha Benjamin argues of a theoretical new Jim Code, where supposedly neutral technological systems and fixes often obscure social distinctions and racial discrimination. She defines the theory as the employment of new technologies that reflect and reproduce existing inequities, but that are promoted and perceived as more objective or progressive than the discriminatory systems of a previous era. Technological systems that ignore broader conversations of social distinctions embedded in the era in which they emerge ultimately deepen the fissure of racism in what Benjamin calls default discrimination. The unexpectedly high mortality rate of diabetic amputations is an important issue that needs to be addressed through medical intervention, awareness, and legislation. Yet amputations are also about chronic disability and which forms of disability warrant sympathy and which ones do not. Amputations are made visible through the lens of disability, race, and the built environment. House ramps and wheelchairs dot landscapes in neighborhoods with high amputation rates and used as symbols of Black irresponsibility and neglect of their own health, often ignoring the systematic discrimination in medicine and public health that many continue to experience. The disfigurement of diabetics is rarely held up as a symbol of disability. A brief comparison can be made between diabetes and Ewing's disease, a rare cancer of the bones that can lead to amputation in children and young adults. Ewing's disease is posited as a blameless disease, an amputation courageously faced, as opposed to diabetics, where the common narrative suggests they suffer amputations because of personal fault. Prosthetic limbs are a symbol of resiliency and technological pride in the image of white survivors of Ewing's disease. But in Black diabetics, artificial limbs are racially stigmatized. Rather than upheld through the lens of being courageously disabled, Black diabetics with prosthetics are blamed for their own pain and suffering, while their presence in public spaces met with disdain and contempt. And so part of the work of historians is to reshape complicated narratives and to make usable for scholars and the broader public. Now, I've sort of come to a little bit of a sort of understanding of where I am in my career. I am definitely mid-career, as they say. And as a mid-career scholar, I'm taking stock, so to speak, of changes that I want to make in my scholarship, but also how I outwardly face the work that I do. And so I'm sort of deliberately pushing myself to become a little bit more active in thinking about how my work can influence possibly policy, but also individuals' lives in terms of thinking about the long misconceptions of diabetes throughout the 20th century. When you're writing a book like this, there are two things that happen. Number one, you become cognizant of your own health. Number one, that's inevitable. And number two, you become a bit angry at how people are being treated, and that you have something to possibly say that could alleviate some of the pain and suffering that people are going through. So I think this is part of the evolution, I think, of myself as a scholar. My work has a political ambition to transform and reverse misguided perceptions of diabetes. And I hope that this work engages with scholars, activists, health providers, patients, policymakers, and the broader public, in the process making visible that which has long been incomprehensible. Politicians, health organizations, and public health officials are finally starting to take note of the diabetes amputation epidemic. The Amputation Reduction and Compassion Act was recently introduced by Donald Payne of New Jersey. Among the goals of this legislation are to make PAD screening a requirement before an amputation can occur, prevent physician reimbursement without proper screening, include a public education initiative, and expand Medicare and Medicaid coverage to include PAD screening at no cost to patients. And so as I stay on this soapbox, I do think that there is a role for the scholar in bringing about significant change. And much of this recent change was the result of a really good essay by journalist Lizzie Presser in ProPublica that was published over the summer. If you haven't read it, you should definitely take a look. It was a really good essay on amputations and diabetes. I actually had the great pleasure of talking to Lizzie Presser about another piece that she wrote a couple of months ago. And so the Amputation Act was in many ways a result of this sort of research and activism on the part of many diabetics and those who were suffering from amputations. The 1972 Dialysis Entitlement Act made access to dialysis under Medicare a reality for millions suffering from kidney failure and end-stage renal disease. We should similarly extend the public charge of Medicare and Medicaid for PAD screening to help reverse the current diabetes epidemic. I'm going to stay on the soapbox for one moment. Diabetes organizations, including the ADA and patient groups, can also lobby for treatment changes. The ADA has historically been very conservative in lobbying for Black diabetics. More than ever, patient groups are now demanding that the ADA address their many needs in terms of resources and policy. Amputation should be a last resort after all treatment and therapeutic options have been exhausted. Screening for PAD and surgery must be an option before the life-changing decision to cut a person's limb. Physicians should have to justify amputations and be incentivized to provide non-amputation related treatment. In our current political climate, national legislation to provide more access to resources and ensure equitable health care remains difficult. Clinics that screen for PAD should be opened in rural and underserved communities. The dangers of poor glucose management and amputations must be made visible in public health campaigns, radio, social media, and medical training programs, just like breast cancer and other disease awareness programs. All of this is required to help reverse this amputation and diabetes epidemic. I often make the point that diabetes is a window into the nation's health. Amputations in the United States have been increasing since the economic recession of 2007, and shows the ways in which broader societal disruptions can lead to disability and death. So all of this is important for understanding our current moment and our current situation with the SARS-CoV-2 pandemic and diabetes. So what happens when a sudden pandemic in SARS coronavirus 2 meets an old metabolic disease in diabetes? By early April, experts on social disparities in public health in the United States were describing an epidemic of Black suffering within the COVID-19 epidemic. The coming disaster was anticipated and feared by many who understood the historical vulnerability of African Americans. News coverage began to focus on the increased susceptibility of Latinos and African Americans who suffer comorbidities of heart disease, hypertension, and asthma. COVID-19 attacks the immune system, and mounting evidence it causes underlying autoimmune conditions to flare led to a sudden awareness of long ignored chronic conditions among African Americans. Rheumatoid arthritis, lupus, multiple sclerosis, type 1 diabetes have all taken on new meaning. According to the Lupus Foundation of America, African American women are 3 times more likely to suffer from this autoimmune disease, where the body's immune system attacks its own healthy tissues, causing a weakening of internal organs and joints. Those with lupus have long known about the need for social distancing, wearing a mask in public, and fear of public spaces. Diabetes is a dangerous COVID-19 comorbidity for social and biological reasons. Finding ways to exercise, eat healthy, manage stress and glucose levels, and make routine appointments with specialists to manage their disease is essential for every diabetic. This level of care is particularly crucial during the current epidemic. For some diabetics, the necessity of exercising inside or outside is laced with the fear of multi-generational family members who might become infected and lack of usable green spaces in neglected neighborhoods. Fears of leaving the home for specialist appointments, cancellation, or the delaying of appointments have led to a smoldering epidemic of diabetes and related complications nationwide. In May of 2020, the World Health Organization warned that numerous parts of the globe were suspending diabetic-related services that would cause long-term harm. Amputations have increased across the world during the COVID-19 pandemic as foot care is delayed, wound care centers and clinics closed, and available beds for non-COVID related illness reduced. The likelihood of gangrene and severe PAD leading to an emergency is higher in the United States and other countries. In some parts of the United States, the rates of major amputations during the pandemic has tripled. Delaying care is dangerous for diabetics under any circumstance, even a pandemic. Diabetes and COVID-19 coincide with yet another epidemic, poverty and inequality. Housing insecurity, segregated neighborhoods, low wages, and being uninsured and underinsured add to the dangers. Diabetics who live below the federal poverty line have long faced the repercussions of not being able to manage their disease and complications. Where people live, access to physicians, dentists, grocery stores, pharmacies, and parks, and whether they can afford the high cost of insulin makes the current collision with COVID-19 disastrous. Access to insulin is part of the long arc of diabetes. The year 2021 will mark 100 years since the insulin revolution that transformed the lives of millions of diabetics and transformed diabetes from a deadly disease into a chronic illness. Insulin was one of the world's first wonder drugs, and though affording the opportunity of a longer life, chronic complications now define the disease. Insulin remains far out of reach for many Americans due to high costs, as much as $450 per month for the uninsured. The unaffordability of insulin over the course of a century is a shameful disaster. And I'm still on my soapbox here. Right? The global advocacy for generic, biosimilar, and affordable brand name insulin is critical in moments of disaster, as access to insulin has life and death consequences. The lack of generic insulin has helped to fuel the global diabetes pandemic and makes visible the unique vulnerability of an ancient affliction to a new disease. The Centers for Disease Control highlighted that diabetes is an underlying factor in almost half of those who have died of COVID-19 among those under 65 years of age. Diabetes causes inflammation that weakens the immune system to fight viruses and infections. For type 1 and type 2 diabetics, obesity is an added layer that makes a dual COVID-19 diagnosis dangerous. Obesity prompts a continual response from the immune system or chronic inflammatory status that can make individuals susceptible to viruses and bacteria. As one physician noted, of the numerous issues that need to be monitored when becoming ill with COVID, you need to be able to breathe. You need to have optimal circulatory function. When we develop obesity, this physician argued, we have excess energy storage, and the presence of that fat is inflammatory. And so once we get coronavirus infection, we are less able to mount an appropriate immune response because our immune system is already being set off in an inappropriate manner by the presence of obesity. There is also early worrisome data that COVID-19 might precipitate new onset metabolic diabetes. One route that SARS-CoV-2 spike proteins enter cells is binding to ACE2 receptors expressed in various organs and tissues in the body, among them the pancreas and kidneys. It has been suggested by many diabetologists and other specialists that some people with diabetes produce more ACE2 receptors in tissues and blood vessels, providing more cellular access to the SARS-CoV-2 virus in ways that might damage B cells and cause hyperglycemia and impaired insulin functioning. In an editorial published in the New England Journal of Medicine, researchers suggested that in the aggregate, these observations provide support for the hypothesis of a potential diabetogenic effect of COVID-19, beyond the well-recognized stress response associated with severe illness. In June of 2020, a group of international scholars created a global registry, an information database called COVID Diabetes. It's spelled COVID-DIAB. The organization's website suggests the aim of the database is to research diabetes comorbidity risk factors and potential connections between SARS-CoV-2 and novel pathophysiological presentations of diabetes. To be sure, at this moment, there are more questions than answers. This is, in many ways, the dilemma of writing history that is currently unfolding before our eyes. Can we predict this correlation between COVID-19 and diabetes with some level of certainty? Is this connection more frequently seen as type 1 or type 2, or does it produce an altogether new pathology of the disease? Does COVID-19 change the pathology of those with pre-existing diabetes? These are questions that are still up in the air. In a previous essay that I wrote back in March of 2020 in the journal ISIS, I talked about diabetes and Hurricane Katrina. Among the arguments that I was making in this particular piece was that many people, individuals who survived Hurricane Katrina and showed up at the New Orleans Convention Center, at Louis Armstrong International Airport, in Baton Rouge, in Houston, and other cities across the country, were diagnosed with diabetes when they were in the hospital in the emergency rooms for other illnesses. So they did not know that they were diabetics, but in the process of receiving medical care for other illnesses and diseases and issues, it was discovered that they were long undiagnosed diabetics. And so this goes back again to the beginning of my talk in terms of misdiagnosis, neglect, and sort of the negligence, so to speak, of of diabetics throughout the course of the 20th century and into the 21st century as well. So these are difficult questions to address amid an ongoing pandemic. Yet the answers hold important truths for that difficult question of when an epidemic will come to an end. For some, perhaps it will end with a vaccine or a therapeutic agent. But for others, the recent troubling observations warrant concern that COVID-19 will become part of a chronic life of disease and disability. So in conclusion, there are remarkably few moments when people are aware that they are living in a historical moment. This will not be the last epidemic or pandemic our society will face, and experts are already suggesting diseases on the horizon may be even more transmissible and deadly than the current SARS-CoV-2 virus. In preparation for the next big one, the societal factors that influence who is more likely to suffer or not during a crisis must be addressed in policies that remedy systematic racism in every aspect of American society. Our current crisis will be written about extensively, as much as the HIV/AIDS epidemic of the 1980s, tuberculosis of the 19th and 20th century, polio of the 20th century, and the 1918-1919 influenza epidemic, all of which are understood both in terms of science and the broader social and political changes they help to bring about, and perhaps just as important, failed to materialize universally across society. When the COVID-19 pandemic enters the annals of human record, will this moment signal a historical shift in truly transforming American society, or yet another lost opportunity? In the midst of the pandemic, the bodies of African Americans continue to be devalued as they have for centuries. Mutilated, tortured, set afire, cut, dismembered, and murdered. The current amputation epidemic in Black communities is a stark reminder of the enduring complications of diabetes and the ways in which harsh environmental landscapes and systematic medical neglect since the civil rights era informed this moment of disability, lost limbs, and lives cut painfully short. There is a willful ignorance when it comes to diabetic amputations. Addressing the epidemic will require broad reform in society and delivery of healthcare, including making sure diabetics are insured and can readily access specialists, insulin, and live in healthy environments. Until addressed, we will continue to see a metaphorical mountain of legs, toes, and feet piling up. The lives of American citizens amputated out of the body politic, piece by piece. Thank you.
Thank you so much, Dr. Richard Mizelle. This would be, as I said at the top, were we meeting in person, this would be the time where you would hear the thunderous applause, which I'm certain by the comments that are coming through in the chat room and in the questions, the Q&A box in Zoom, if that is any indication of the enthusiasm for this work, we can assume that you would have had a thunderous applause in this one. Thank you so much, Dr. Mizelle. There's a lot to chew on. I was reminded that word for word, pound for pound, you are one of the most, I guess, you know how to really pack in so many concepts into one talk. I've got like a couple of pages here of notes and questions that I know I want to squeeze in, but I want to also look at some of the questions that members of our audience have put in. So shall we go at it?
Yeah.
Yeah. All right. You still got some energy left, right? That was a great talk. We're good to go. All right. I'm sorry. I'm looking over here because this is where I have you on the screen in front of me is where I have our questions. I want to go, as I mentioned before, our good colleague, George Chauncey is with us. And he thanks you for a really illuminating talk and recalls that, quote, I first noticed the racialization of diabetes when conducting oral histories with other gay men for a book on New York City's queer history, and was struck by how many of the older Black gay men I interviewed had diabetes or mentioned friends who had suffered amputations. I regret not having followed up on their observations. I wonder if you could say a little more about the, quote, culture of diabetes, unquote, in Black communities, if we can speak of such a thing. To what extent did Black communities recognize the racial specificity of the diabetes epidemic and respond to it? Was there a distinctive way in the way African Americans understood the causes of diabetes? Were they more likely than whites, for instance, to blame it on personal failings versus larger structural forces? What warnings and advice circulated? Thanks, George Chauncey. And thank you, George, for that excellent question.
Yeah, as you know, Sam, the racialization of diabetes goes, back to, prior to the 20th century, of course, when diabetes was largely considered to be a disease of whiteness, in particular of Jewish identity. And so the perception was that African Americans could not suffer from diabetes because they were not civilized enough to suffer from diabetes. That in those rare moments in which someone saw a case of diabetes among someone who was African American, it was explained away that they had white blood or they were light skinned or the body had somehow become temporarily confused. But that nonetheless did not do away with the fact of so-called African American immunity. African Americans, of course, in the Black insurance company industries and others sort of knew this not to be true. And they knew that African Americans were suffering from diabetes in rates that were particularly high in some places like Baltimore and Atlanta. And so from the early 20th century, you see this narrative, and I'm not going to say that I have a lot of firsthand information from African Americans in the early part of the 20th century. But if you take the words of African American physician James T.W. Granady, who presented in front of the National Medical Association in the 1930s, he said that this was a problem and that African Americans needed to address this through proper eating habits and other forms of self-care. And so what that says is that there was an awareness of what caused diabetes, how diabetes was becoming an epidemic in Black communities, but also what African Americans needed to do to protect themselves against this insidious disease. And I think that is part of sort of the longer trajectory of diabetes in terms of those individuals who know individuals who are suffering from diabetes, who have diabetes themselves, but also are going against this broader narrative of who suffers from diabetes and who does not. As well as I do, Sam, when you're giving talks, people come and they tell you all kinds of stories. I think my granddaddy had diabetes. Well, he might have, but he might have or we might not have. But the fact is that this was clearly something that was in the consciousness of African Americans in the early part of the 20th century, and an important part of their consciousness in the middle part of the 20th century and the latter part of the 20th century as well. And so I think that for African Americans, when they began to really sort of think about this disease by the 1950s and 1960s during the Civil Rights era, they began to make changes to their own behavior and sort of patterns in a way that would hopefully protect them from the ravages of this disease, even though they were being hit with this particular epidemic in record numbers.
It's Granady's injunction to take better care of yourselves, I think was the phrase you used. I assume that was about dietary care in particular, and perhaps also exercise. And in the 1930s, it strikes me that telling people to eat better in the middle of the Great Depression is, it's like one could think of other ways to be more critical about the social determinants of health, and certainly the geography of health. As you point out, I think the quote you used was zip codes tell the story, right? And that's not something that was unknown in the 1930s. In a lot of ways, things that we knew in the 1930s, we ended up forgetting by the 60s, 70s, and 80s and 90s with the rage of biomedicalization, as opposed to just good preventive medicine. There's a lot going on here. I wanted to ask you about going back to the prosthetics and the stigma. There's a lot there, and that was in the first half of your talk, and God knows I've had plenty of time to think about what I want to say, and I still haven't. So I'm going to kind of think this one out a little bit. But this is nothing new between you and I. Typically, when we see each other at our conferences, which we haven't, this is what we do. I bounce ideas off of you and get some good insights. But there seems to me a way in which there are, on one hand, like you said, the prosthetics, there are barriers to entry, or barriers to access, which are mainly financial. And then, of course, to whom these are marketed, which is people with a lighter skin complexion. Lack of knowledge of what's available. And then, as you said, lack of access and knowledge about ways to prevent the amputation, the revascularization process, all of those. And then at the other hand, within diabetic communities, of which I'm not a part necessarily. And when I say diabetic communities, meaning not because of my disease status, like people who identify and do diabetic activism is what I'm talking about. Right. There is a movement of biohacking, where there's apps that you can download. You can fashion your own devices. You download the blueprints online, where you get automatic injection pumps. I've seen a couple of friends and students who, or not students, but fellow scholars with whom I've worked, who have these biohacked mechanisms that are kind of patched into their sides and pump insulin at a regular basis in ways that they can control with their smartphones. And it occurs to me that these are all kind of differentiated symbols of, or differentiated prosthetics, whereas having a prosthetic limb and a leg that is of the wrong skin color, or mismatched skin color, not wrong, but mismatched, that may not be technologically sophisticated. And then you're on top of that Black, comes with a stigma, whereas there's also not so much the case with this biohacking thing, which is incredibly fascinating, and people who are very proud about it. In a lot of ways, like the stigma, I'm not making a statement or a question about the reducibility of stigma to one thing or another, but it certainly seems that a lot of that intersection is between the disability, perceived disability, but perhaps more importantly, perhaps less importantly, the skin color of the person, of the body that's inhabiting that. Yeah. And we see this, I think, also, just to add to that, with the Dolphy piece, which I don't think I knew that first of all, that he had died of diabetes. And secondly, that he had died being presumed a heroin user, because this is it was 68 when he died? 64, right. Mm-hmm. This was a period where in social science, can you hear me all right, by the way? Mm-hmm. Yeah, okay, all right. There's a little bit of feedback. I'm gonna put my microphone a little higher. That was assumed of a lot of Black people, they were heroin users. And so there's, in a lot of ways, it always strikes me thinking about this period and seeing not Dolphy, but other people, and then hearing your talk, that there's a kind of, I want to resist calling it a phantom limb, but it's like almost a phantom amputation that follows us around. There's always a presumption, like, not in Dolphy's case, he was misdiagnosed, but there's always a presumption of like, there's like diabetes is part of their thing, they don't eat well, et cetera, et cetera. Yeah. And then, in today, when you have pain in a hospital, the doctor will, if you are Black, give you fewer painkillers and a lower amount of prescription, with the assumption that this person might be an addict. There's always that phantom disability that follows Black people around. So I know that was a long way of not making a question, but I want to pick you're used to this. You and I have had many conversations over the years, and you're kind of, I can tell you're thinking this is what Sam does. Yeah, and it is. But so how does that figure into the book? Like this kind of, this haunting, always being presumed to be not in care of your own self, and always, if you're not already a sufferer of a disease, you're on your way to being that, be it heroin addiction, be it some sort of behavioral health issue, be it diabetes and amputation. How does that figure in?
Yeah, that's part of the reason why I sort of started with the slippage of type 1 and type 2. Once that, sort of delineation occurred in the 1950s, the shift occurred. The shift occurred from African Americans not suffering from diabetes to personal neglect of their bodies, and therefore more or have a greater possibility of suffering from type 2 diabetes. So I think you're right. There's always this this idea that type 1 diabetics are blameless as well. So similar to the Ewing's disease analogy, type 1 diabetics are considered to be blameless. Like, this is no fault of their own. But type 2 diabetics, which is sort of overwhelmingly considered to be African Americans, are a group of individuals who the assumption is they are suffering because they have poor eating habits, don't exercise, and do not do what they're supposed to do to manage their disease, and therefore are not warranting of support and resources. And that is a stigma that has stayed with African Americans and diabetics, or African American diabetics, throughout the latter part of the 20th century. And it makes its way into the conversation so much that it is in some ways difficult to sort of find an entry point, because when I give these talks, I have to constantly disabuse people of the fact that African Americans suffer from type 1 diabetes too, right? And white people and other groups suffer from type 2 diabetes. But this, ever looming perception of Black vulnerability and Black fault comes up, even in grants, even when I'm writing about diabetes. Well, what about this? What about what African Americans are doing in their own sort of personal lives, without talking about the larger sort of social infrastructure that makes it difficult for, in many ways, African Americans to manage their diabetes? The prosthetics piece is a piece that I really just, within the last month or so, began to think about. And I was happy to do that because it kind of brings me back to one of my original interests, which is race and technology, which I've kind of gone away from a little bit. But that whole idea of walking around with a white prosthetic limb when you're not white, I mean, that's psychologically damaging. And the fact that that you can't do anything about it if you can't, if you don't have the resources to find a limb that matches, right? And in this particular sort of talk, I wanted to highlight that in the sense of how difficult it is to find these resources when you are poor and when you don't have access. And so that point about having to replace every 3 to 5 years, if you gain weight, if you lose weight, you need a new prosthetic limb. In my naive way of thinking, I hadn't really thought about it until I was doing research. You got one prosthetic limb and it lasts you 20, 30 years. No, sir, that's not how it works, right? You have to constantly change. And who has the ability to make those changes, and who has the ability to access the psychological resources necessary to deal with this amputation, really comes down to access and race and class. And so that phantom limb of always constantly being considered negligible of your own health when you're actually doing everything in your power to survive, that's part of the psychological distress of diabetes as well. From Dolphy through Malik Taylor up until the current moment, people are often and constantly fighting for their own visibility within this particular disease and access to resources that will help them to manage this disease.
I also noted how you refer to Malik Taylor by his official name, aka Fife. Fife Dog. Yeah. Rest in power. We have in the chat room or in the Q&A, and I want to say at this point, remind our audience, please put your questions in the Q&A window, not the chat room necessarily, even though we will try to monitor both. Also, a little bit of station identification. Our Twitter handle at the Lehman Center is at CU Lehman Center, CU as in Columbia University, LEHMAN CENTER. You can hit us up there, follow us there on Twitter. Felisa DeRose, and apologies if I mispronounce your name or anybody else's, asked you, Dr. Mizelle, as a literature professor who also writes about diabetes and as a diabetes lifestyle blogger who was misdiagnosed with T2, type 2 diabetes for 8 years, I want to know if you discuss latent autoimmune diabetes in adults, also known as LADA, LADA, or type 1.5. I've never heard of this, but I'm not a scholar here. If you discuss this in your project, or do you solely refer to type 1 or type 2 as your framework?
I solely refer to type 1 and type 2. I do also, well, I will talk a little bit about MODY, mature onset diabetes of the youth, of the young, in which there's, again, sort of this sort of new, a relatively new pathophysiology of diabetes and sort of understanding of how diabetes works, but also what essentially looks like type 1 diabetes in individuals who are older. So at this point, I will say that I mostly suffer, or I must mostly work on type 1 or type 2 diabetes, but also when appropriate, think about some of these other sort of conversations as well. More recently, maybe in the last 10, 15 years, there's been some discussion of what's called a type 3 diabetes, which is tied to, in some ways, Alzheimer's disease, right? So some have argued that the brain produces insulin in much the same way as the pancreas. And so when the brain becomes insulin resistant, that is essentially a form of diabetes and sort of type 3. So there's, I think in many ways, that's what's so fascinating and difficult about this project, that there's still so much about this disease that we don't know. And throughout the course of the 20th century, you can sort of see this evolving sort of knowledge occurring between scientists and physicians and researchers. When people were diagnosed, of course, there was a strong eugenic element to diabetes in the mid part of the 20th century. So the perception that diabetes could be passed on like other sort of ideas of eugenics through 3 generations, right? You actually see this, 3 generations of diabetics are enough, as sort of people sort of fought to prevent certain individuals from entering into their gene pool through reproduction. So diabetes, that's why in the very beginning, I say it touches on so much of American history that it's impossible to do it all. But the ways in which it sort of coincides with just about every other narrative of public health and medicine is fascinating.
I don't think I was aware of the eugenic implications of that history, because the 3 generations of diabetics is enough is, I assume, a direct lift from, and I'm blanking on the Supreme Court justice. Was it the Buck v. Bell? Yeah, who said 3 generations of imbeciles is enough.
Yeah.
Is that
so there was a lot of stigma of diabetics in the 1940s and 1950s. In many ways, they had a difficult time getting jobs. If you were an insurance company agency, you had to get a letter from your physician that you would not fall into a diabetic coma while going around selling insurance. People hid their people hid their status from potential suitors because they did not want to marry someone who was a diabetic. And so people feared diabetics in a way that we haven't really, come to grips with in terms of sort of thinking about that long history of neglect and stigma. To the point where some families forbade a person from marrying someone else because that person had diabetes. And so, again, that goes back to sort of the sort of misunderstanding or neglect and sort of discrimination towards diabetics throughout the 20th century.
My goodness, I did not know that. And you said the 40s and 50s. I mean, because the narrative is that that's kind of when, a lot of people said, yeah, maybe we should rethink this eugenics thing, given what, recent events, shall we say.
Yeah. I mean, there was an argument that brunettes suffered from diabetics more than blondes. I mean, you see all, which was sort of tied into sort of questions of eugenics and genes and all kinds of stuff. So, yeah.
Yeah. Wow. Aya Nuruddin is joining us. And she hails you. She says, thank you for a fascinating talk, and wants to ask you, can you speak a little bit more about the stigma of diabetic amputation in comparison to amputations from other diseases or injuries? I'm curious of other kinds of I'm curious about other kinds of amputations which may or may not carry different forms stigma of racialization. That's Aya Naradine, brilliant graduate student down at Hopkins, says, thank you for the talk, and has that question.
Thank you, Aya. Yeah, I think that in the talk, I talked about this sort of idea of disability, or what you might call valorized disability, lack of a better term, right? So this idea that some amputations should be born with sort of valor and grace, and that you're courageous. And sort of Ewing's disease is one type of disease, but other sort of diseases or injuries are not sort of, viewed with a certain stigma when it comes to, publicly facing or being in public spaces. And that is a result of, in many ways, campaigning, right? These people are courageous. These people should not be made to feel bad about their amputee status, that this is what is necessary for their survival. I think when you talk to Black diabetics, their experiences is a little bit different. And when I say their experience is a little bit different, I mean in the neighborhoods in which they live, in which they are looked upon with, disgust, that people automatically assume that, you can't look at someone who has an amputated leg and assume that they're diabetic. But the assumption for many of them is that people look at them as if they assume that they are neglectful of their own bodies and suffering from diabetes and eating things that they are not supposed to be eating. And whether any of that is true is irrelevant, but that's how they feel. But they also feel this in physician offices as well. I didn't go as much into this, but sort of the bias that many people feel when they are entering into clinics, when they're entering into hospitals, when they inquire about different treatments, when they disclose the fact that they are diabetic and they have suffered an amputation, or they suffered an amputation last year or 2 years ago, their treatment changes. And they are, in many ways, going back to what you were saying, Sam, sort of put in a certain box of neglect. And then that sort of ties into sort of a longer history of mistrust. And then those individuals become fearful of going to the physician for fear of another amputation occurring, or becoming disgusted at their own interactions with physicians and not wanting to interact with that physician or nurse in the future. So it then becomes sort of a cascading effect of mistreatment by physicians, but also those patients not wanting to endure that mistrust. Right. If you, a good friend of mine at the University of Texas, who's also writing history of diabetes, talks about patients in doctors' offices who physicians or nurses don't want to touch their legs or don't want to touch their feet when they're clearly suffering, and how that makes them feel, like their disease is not given the attention of someone else who might be suffering, or who might also be at risk of losing a limb. And the reason they feel that people do not want to touch them is because of their skin color, because of their race and ethnicity. And all of that then takes a long toll on them psychologically and physically over the course of their lifespan. And all of that then becomes an important issue when thinking about how diabetics interact with the medical environment, but also how they interact with people on the street, and also the physical environment as well.
Yeah, that says a lot in our current discussion, misguided as it often is, about vaccine hesitancy in Black communities. And, the touchstone is always Tuskegee, as though that's the only thing that's happened in recent memory to make Black people be a little suspicious.
They don't have to go to Tuskegee. They can go to East Baltimore the day before yesterday, right?
Yeah. Indeed. I know we promised to let you go at more or less at the 5:30, but we have a couple of great questions here, if you don't mind, at least squeeze in perhaps one of them. Antoine Johnson, who another brilliant scholar from UC San Francisco Medical Center History of Medicine program there, who, as you know, has been working on HIV and AIDS activism and organization and research, and has a question that goes to the intersection of your research and his. He says, with HIV/AIDS, colorblind approaches were employed, stating that condom use would mitigate the spread of the virus. They targeted primarily, these interventions were targeted primarily towards gay white communities. Many Black vulnerable groups contracted the disease through intravenous drug use and were told behavioral changes would reduce their infection rate, irrespective of poverty and inadequate access to healthcare. Can you elaborate more on the racial dynamics of behavior and victim blaming narratives across ethnicities in the diabetes industry? Food deserts, as you said, increase one's susceptibility. How do we illuminate ways state-sanctioned violence contributes to disproportionate disease rates among African Americans? That's the end of the question there. And he, Antoine, characteristically packed really 3 questions into one. These are all great ones. Take a stab at them, though, please.
Yeah, I mean, I think that if we're serious about this question of racism being a public health threat, then it ties into diabetes as well, because there is a narrative of stress that is important in thinking about diabetes. I keep talking about the 1950s, but in the 1950s, there was sort of this narrative that if you, for example, got into a car accident, then you could get diabetes. Well, that's kind of been debunked, but the broader issue is, what role does a stressful environment, as Antoine would say, state-sanctioned violence play in onset of diabetes? And I would argue that it's a lot, right? In terms of, where people live, how people interact, even in the current coronavirus. I think how people sort of interact with state-sanctioned infrastructural policies and institutions play an important role in sort of the onset of type 1 diabetes, but also type 2 as well, and the exacerbation of type 2 diabetes. Part of what I'm doing with this project as well is sort of thinking about sort of the chronic endemic aspect of diabetes, right? So at some point, SARS will end, but diabetes is still with us, and it has been epidemic because we have not done the things to systematically change the lives and the access and resources of so many people throughout society. And until we do that, this epidemic of diabetes will continue to rage. Another important point is sort of, I think Antoine is making a really good point, which is, that whole sort of victim blaming, aspect or issue that, again, that people are suffering from diabetes because of poor eating habits. And you see this at the highest levels as well. As one particular scholar sort of wrote years ago, Michael Montoya, if you write a grant on African Americans, or if you write a grant on diabetes in among whites in Boston, that grant will not get funded, right? You don't have a shot. But if you write a grant on diabetes and African Americans in New Orleans or Latinos in McAllen, Texas, then that might get funded, because again, there's this even state-sanctioned perception that only African Americans or minorities suffer from diabetes, and that only the research that deals with how African Americans can, change their own habits or eating patterns is worthy of support. Is how only that kind of research is worthy of support, and thinking about how African Americans can reverse their own particular politics or behavior. That's part of the problem, right? And thinking about this sort of state-sanctioned violence and how we might, really push to change that narrative. So we have to really understand and push back on that idea of sort of color blindness, and really think specifically about, how the policies that are in place are specifically impacting not just African Americans, but other groups of people as well.
My good colleague, thank you for that. My good colleague, I know we're a few minutes late, but I did want to get this one in as well. And thank you, Antoine, for that great question. My good colleague here, Betsy Blackmar, has a question, which actually really dovetails well into what your previous statement. She also thanks you for such an illuminating talk. Could you say something about the politics of research into diabetes, as well as access to affordable diagnostics, as well as treatments like insulin? I think you kind of touched about the politics of research, but maybe a bit more about access to treatment.
Yeah, I mean, I think that there's so much in so what you were talking about with sort of what's called a diabetic cyborg, and sort of the treatment of sort of insulin, and that can be managed and adjusted on the fly by each individual. You know, those things are happening, and they're happening to a significant degree, but they're also leaving behind poor people who don't have access to the technologies that are required to be able to self-manage their own diabetes. Diabetes has always been a disease of self-management, self-actualization, and self-surveillance, you know, from the early part of the 20th century to yesterday. And so making everything treatment, therapeutic options available, making insulin available, all of those are the things that will help to reverse this particular pandemic. And so I think that insulin is the key. You know, as a good friend Jeremy Green has written quite a bit about this, about making insulin affordable. But I also think that you know, changing, again, sound like a broken record, but the policies that make access to the therapeutics more readily available, but also in changes in the environment that would help people who live healthier lives. All of those, I think, would help to reduce this pandemic.
Well, you have given us a lot to think about. Thank you so much for joining us. We're looking forward to more of your published work and the book as well. And we'll make sure to have you back as this story unfolds, because I think you've made it clear. Certainly the contemporary politics and issues aren't going anywhere, unfortunately, and we will continue to bring you back for further insights. In the meantime, this would be where we would give you the standing ovation, Dr. Mizelle, but you're just going to have to imagine it. And take instead our sincere thanks on behalf of the Lehman Center for American History and Columbia University. Thank you so much. Continue to be safe, and looking forward to catching up with you soon when this pandemic lifts.
Yeah. Sounds good. Thank you so much for having me and for all of the great questions. I really appreciate it.
Thank you. Much appreciated. Take care, everybody. We'll see you soon for our next events. Please do check out our website. And as I said, CU Lehman Center is our Twitter handle. We will also be announcing more events to come. Take care, everybody. Thank you. I think, Rick, you could stick around.